Welcome to Anderson Medicine, a new show. This is actually our first show about medicine in Anderson. And our first guest, our important guest today, is the medical director of Mercy Anderson's Hospital. And I want to start with an introduction. You know, following an accident, you're transported to the nearest emergency department by emergency medicine medical services. The first thing you remember is looking up to a doctor in a white coat. It's very scary. It's very loud. Who runs this place? Does he know what he's doing? Let's talk to the medical director. So our guest today is Dr. Michael Argus, who's been at the emergency department across the street at Anderson Hospital for the last 10 years. He graduated from the University of Cincinnati College of Medicine, graduated from Ohio State University residency program, and served as chief resident for a year, and has been our medical director, he says, for 3 years, but really 4 years when the new group. Welcome, Dr. Argus.
Well, thanks for having me. Appreciate the time being here.
So, you know, first of all, is it called the ER or the ED? In other words, is it the emergency room or the emergency department?
Well, I think emergency room or ER was a show, a really good show, a show that actually brought a lot of people into the field. But we have 32 emergency rooms. We've got one emergency department.
So, and the word ED kind of has other connotations, and so ER kind of. We actually still go down to the ER when we come to see you. And so just give us an idea about the Anderson Emergency Department, number of patients, emergency medicine services. What do you guys do?
Well, it's unscheduled care. It's acute care, so we don't know exactly how many patients we're going to see on any given day. But we know we see around 120 to 130 patients most days. We get a number of EMS runs, so about 20 to 25 squads. We admit 20 to 25% of the patients that come in. The rest of the patients that come in, that other 100 or so patients, walk in the door with any number of complaints. They can be any age, from just being born to actively being born to in their hundreds, and we see all of them.
So how do you call the helicopter, or does the helicopter call you when it shows up?
Well, Uber doesn't have an app for that yet, but we do call the helicopter. We let them know. Occasionally, when somebody has some sort of severe trauma, they will bring the patient to us to stabilize, and then en route to, say, the trauma center locally, which is University of Cincinnati.
So as in emergency medicine, how do you interact with other physicians, a primary care physician, a specialist?
Well, I think of us as somebody who's on the front lines. A lot of times we're at the very beginning of somebody's severe illness. Sometimes the patients are coming to us from doctors' offices. Sometimes they're coming to us from urgent cares. They can come from the scene of their accident, but we're just a part of their care. We're maybe an hour to 4 or 5 hours worth of their worst day, and the family doctor, the primary doctor, the hospitalist, the surgeon, those people are going to be involved for days, months, and years of the patient's care.
So what's the difference if somebody arrives, like they pull up and go to the waiting room, versus getting driven in by the big red truck with the light on top?
Well, there's certainly a little more concern for somebody that's coming in, lights and sirens, that an EMS provider has called you about beforehand, and you've gotten a room ready, because you know they've been seen already by a provider. They're pretty sick. We know historically almost half of the patients that arrive by ambulance are going to be admitted to the hospital. That means they're simply a sicker part of the population. But the patients who walk in, boy, they can be quite sick as well. And so those patients are treated very quickly. They're triaged very quickly. And we're ready to see them right away as well.
So you get called by the squad, when they're en route, and what kind of stuff do they tell you, or how do you know what's coming?
Well, so, we talk in a lot of medical jargon. So, we talk about the age, gender, and comorbidities of a patient. So you might say a 72-year-old female with COPD who's short of breath, or they might say a 95-year-old male with chest pain. And they'll describe their EKG, they'll transmit it over to us. They'll describe certain things about the home situation that may have got them here so that you're attuned to that as well. So it's short, but it gives you enough information to know what you're going to need when they arrive.
So the EKG in the field, which has only been going on for a couple of years, in fact, it was kind of piloted and started here.
Yeah.
They can diagnose a heart attack in the field. What do you do differently when that occurs?
Oh, that's a great question. So if somebody has an EKG in the field that's markedly abnormal, that we look at and we say, this is a heart attack, then we actually get everybody ready, the cardiac catheterization team, meaning the interventional cardiologist, the whole team of nurses and technicians that come, if it's during the day, they're on site. If it's the middle of the night and the weekend, they'll be coming on one pager all from home, even arriving before the patient arrives at times.
So someone's sick or ill or injured, how would they decide they need to go to the emergency department, at the hospital, go to urgent care? Cincinnati Children's has an urgent care across the street. What would be a good advice for them to kind of choose?
So that's a really good question. So we see all comers, and every doc who's there, every provider who's there is trained to see adults and children. And we're certainly comfortable taking care of more minor things, but I like to think of this as the place to come when you're sick. And so what emergency means to any individual certainly applies. So when you ask people after their visits, even if they were diagnosed with a cold, well, they were concerned they had pneumonia. And if you saw somebody with a turned ankle that turns out it was just sprained, they were concerned they broke their leg. So all of those things are emergencies, and so you have to let us decide in the end how severe it was. We're going to treat you the same. We're going to treat you with compassion and care, even if it turns out to be something that you're going to get over on your own, that your body's going to take care of on your own.
So do people call and I have this, and to the emergency, they call the emergency room? All
the time, every day.
And what do you tell them? Can you give advice, or do you have to say, come in? Or?
So, we can't give advice on the phone. When it's somebody that we've just seen, that the doc who saw them is still in the department, is still available by phone, we try to connect those two so that they can really have the best possible advice. But most of the time, it's really hard. It's really hard to make a diagnosis over the phone and to tell somebody what's appropriate to do for them over the phone when you just don't have a set of vitals, eyes on the patient, ears on the patient, and really be able to do what's appropriate for them. My hats off, I should say, to the primary care doctors who take those calls, day and night. It's tough, even with access to their records. It's really tough to make that judgment call on what that patient needs at that time when you can't see them.
Yeah, I mean, it's amazing how difficult it is to figure stuff out. And sometimes we joke the chief complaint of the day is sent in by my doctor.
Yeah.
Half of those folks end up actually getting admitted to the
Absolutely.
hospital and being pretty serious. So about the group, who do you work for? Do you work for the hospital? Do you work for Mercy? What is about your group?
So I work for a group called Emergency Medicine Physicians, or EMP, founded in 1992 by an emergency resident at the time, and now in 16 states and over 60 hospitals. We provide all aspects of acute care, from even urgent care type business to our chief business, which is emergency medicine, even some hospitalist medicine, and crazy enough, telemedicine for those visits that are kind of in between an urgent care visit and the next day before you see your doctor, about earaches, sore throats, rashes, that sort of thing. Telemedicine can be quite a bridge and prevent emergency visits at a much lower cost.
So how is that? So your group, which is really large and nationally based, pretty much all emergency medicine, what's the sort of benefit of that versus just working for the hospital?
Great question. I think a group that specializes in emergency medicine is able to take a wealth of experience. I mean, we see 3 million ED visits a year, whereas the hospital that we work for sees 40,000. And so we have the ability to learn from those experiences, to build best practices, to build quality measurements that might not be available at a local site that only sees a handful of those cases every couple years that might be high risk for their patients and the type of risk they might not be aware of.
So what kind of special training, leadership training that you've had from being part of like a national group?
So in 2010, I went through a program called the Scholars Program. Finished in 2011, and it was a year-long leadership training program. It was there primarily to teach me how to be a good medical director, to be a good steward for the docs that I'm in charge of, and the advanced practice providers as well.
So people come to the emergency department, and hopefully they're released, or if not, they get a bill from kind of some different people.
Yeah.
And so they get a bill from the hospital, and they get a bill from your group.
Mm-hmm.
Where does it come from? And people have questions, like, why did I get like the radiologist? And
yeah, it's a good question. So with any visit, you have to think about all the people that are involved, all the people that are taking care of you. It's not just the doc. It's not just the technician, but you've got a physician, a nurse, lab staff, radiology staff, people who are reading the x-rays, people who are interpreting your blood work, and all those kind of things, and doing all the quality processes. So you tend to have a facility fee, which covers the nursing staff, the laboratory, the radiology staff, and that. You tend to have then bills from subcontractors like my own group for the physicians' work on that side.
So over the last 4 years, you've really built this group of core physicians here from scratch. How'd you do that? And what do you look for when you're looking for a physician colleague to work with you?
That's a great question. So we did start from scratch. It was myself and one other person, Matt Roberts, who's still with me as the assistant director here as well. When we started, it was the two of us and people who were flying in to work here and who did a remarkable job getting the place stabilized during a really tough time. It was a really, really challenging transition, and allowed us to find the right people that are values fits for our organization, people that we think would be with us for a long time, and who are going to be good stewards of the patients in our area. Every single person that you hire, you want to be comfortable with them taking care of your own family member. Someday I'm going to be on that gurney too, and I want them to be able to take great care of me. And so that's the kind of thought process you have when you're looking to hire somebody that's got the right core values for a servant's heart and an owner's mind.
So the docs here, do they rotate around all over, or are they focused on this particular emergency department?
So our docs are just here. They're just at Mercy Anderson. Over the last couple years, we started working. Also working at Springfield Regional Medical Center, and a few of us go out there occasionally to help out when needed. But we're all just here. We're at Mercy Anderson. It's our home.
So if you're just joining us, this is Anderson Medicine. We're talking with the Anderson Hospital Emergency Department Medical Director, Dr. Mike Argus. And so viruses are in the news. A lot of them.
Yeah.
Ebola and measles and flu. How was the flu season this year? Are we still in it?
Well, we're at the very tail end of the flu season in Cincinnati. It is very, very hard. Right around Thanksgiving, Christmas was miserable, right through New Year's, and then by the second week of January, we really started to see things trail off, and now we're really back to a real stable volume, back where we were, before November. But it hit very hard. This was a year I have never seen before, and the reason was that this was not the most protective vaccine that we've ever had. So on top of patients who have been vaccinated and getting sick, you had staff getting sick too. because they weren't particularly well protected. So everyone was in various stages of health and well-being while they're trying to care for the population here. So it was a challenging year, but we're through it, and none worse for the wear.
So the circulating virus this year was this H3N2, which was probably less than a 30% match for the vaccine. There was an antigenic shift. It peaks over 2 weeks. Those 2 weeks happened to be Christmas and New Year. And so did you have to call in some extra docs? Did you have docs go down?
We had docs go down. We had advanced practice providers go down. It was rough. Yes, so we had call-ins, we had call-offs, we had extra shifts, we had it all.
Yeah, I know. I came in hospital medicine, and I think we were happy for any board-certified body that would come in. So a virus that's in the news, hopefully not locally, is Ebola.
Yeah.
In Dallas, a gentleman walked in the ER and had a fever, had exposure, and they missed it. Are we ready? Are we looking for it?
We're definitely ready. We're definitely looking for it. We screen every single patient that arrives. There's a Ebola screening part of our regular electronic health record now, so that every person that comes through gets screened, gets asked a handful of questions that can reliably tell you whether or not the person's at risk, and then we can go from there. So we're doing that on every patient. We're absolutely ready.
So you got the suits.
We have the suits.
Stuff, and so we had a little scare a couple weeks back.
We did.
With a gentleman from Nigeria who everything worked. I was really proud of just how ready we are, and he has the measles. He has the malaria, and was treated appropriately. And the CDC answered the call to the emergency response line, which was very helpful.
Absolutely.
And the guys were great. So actually about measles. So nationally we have an outbreak of measles. Have you ever seen a case of measles?
I haven't.
I have not either. I mean, between the two of us, it's a historical disease. So I guess we haven't seen any measles here locally.
We have not. Ohio is a place that does see small outbreaks, small crops of outbreaks in certain communities that are unvaccinated. Last year was a record year for Ohio, I think our general vaccination rate in Ohio is relatively low.
Yeah.
I think the second lowest in the country.
It is, yeah.
So that is something we're going to have to be aware of. But so far, we really have not seen any cases locally here.
So of the three, influenza, droplet, 3 feet. Ebola, have to have a very high viral load through fluids. Measles spread through the air. In fact, the measles virus could travel like the length of a basketball court. Of the three, we actually are probably a little more frightened of the potential for measles. The good news is there's a vaccine. The vaccine works, and we recommend it, I think. So disaster preparedness. And so were a disaster to occur here locally, you guys are the front line once again. How do you prepare for that?
Well, the preparation, disasters are never fun, but the preparation is, and you don't know when a disaster is going to occur, so you have to be ready and you have to prepare in advance for the unforeseen circumstances that are going to happen. We have a team of, I should say, a group of people here, the Medical Explorers, which are students from some of our local high schools, Turpin, Anderson, Milford, and they help act as actors in scenarios where we have mass casualty events, things that you can think of like environmental contamination, explosions, that sort of thing. And when you prepare that way with lots of actors during a routine day, then you learn what your weaknesses are and how to get better.
So the last disaster drill was with Anderson EMS, the Forest Hills District. There was a truck that exploded, presumably at Anderson High School, which didn't really occur, and the students were brought over. And Anderson EMS, they tried like every way in the world to make it so hard we couldn't figure out what it was.
Yeah, they did a great job.
And they did a very good job at that. And so finally we did, and took care of the folks. We had the students at the end, debrief with us, which was kind of nice. And then the most important part of the day, we fed all the students pizza, and we brought 20 boxes of pizza, and they were gone within like 10 minutes. And so hopefully they were well fed.
They're healthy.
So speaking of community outreach, just this past week we were over at Walnut Hills doing a suture lab. What's that like?
Well, it's a ton of fun. These are students who are juniors and seniors in high school. All of them have some interest in either physical education, medicine, something related. This class is related to injuries, and our part of it is really just making sure that their interest in medicine, we give them just a little taste of what it's like, what the experience of taking care of a sick patient, a traumatic patient is like, and giving them an opportunity to see what we do on a routine day. Suturing somebody up, and in this case we give them bananas to sew up. It's a blast. The kids are great. The time is just so worth it. I just love it.
It's great.
Love it.
I mean, all the bananas lived, apparently. And so they ask some pretty good questions, especially of you. Like a couple of questions. Like one of them is, what grosses you out?
Yeah.
What grosses you out?
Yeah, really funny guy. He said, I don't know if I could handle all that blood. Does that gross you out? No. Well, does anything gross you out? And I said, well, there's a couple things. I don't like to say it. And I just thought, well, yeah, I hate the sound of somebody vomiting. Just the sound makes my stomach a little upset. And for whatever reason, that's something that's just never gotten past me. And for whatever reason, that's just it. But I can take the rest of it, pus, blood, trauma, whatever it is, that doesn't bother me one bit. But the sound of vomit.
I kind of agree,
That's
actually. Yeah. And somebody else asked you, what do you do when you need medical care?
Wow, it's good. Again, you hire the right people so that when you need it, that you can get it. But I've been very, very fortunate that I haven't been very sick. And when I do get sick, I think I know who to call. I've got great partners, great friends that I've trained with, that I went to school with, and I can call on a moment's notice.
So, big news, the Anderson Emergency Department has a soccer team. I'm glad to see that you guys have lived through your first game.
Yes, we did.
What's the name of the team? What do you got?
So it seems like all of our teams, we have a team for the Mercy Marathon as well. They're all called the Frequent Flyers. It's kind of a terrible term. We don't love it, but it just stuck. It is what we are. So we've got docs, nurses, technicians, and friends of all of us, because we do work nights, weekends, and can't get to all the games. But it's a good way. It's a good way to build some camaraderie. It's a good way to blow off steam, and as it turns out, it's a good way to get really winded and learn that you're aging.
I mean, it is a good team. It's an incredible team. You guys have to do a lot of things, including resuscitating young people, all kinds of folks, and I know there's some things that you do after you've had like a 1 or 2 hour trauma recess where everybody's been working together. And what do you do?
Yeah, so we're obviously all human beings. We're all people that have families, that have kids. We're people that have loved ones, and when you resuscitate a kid, when you take care of a young adult, when you take care of somebody who's critically ill, you do so with all your energy, and even with doing that, they still die, or even are so severely injured that the outcome is likely to be a bad one. It affects you. It impacts how you see the world. It impacts how the rest of your day is going to go. And so after any resuscitation like that, we do a debrief. So that's kind of a huddle among the team that worked on the patient. We talk about, what we're experiencing. Sometimes we're crying it out. Sometimes we're just hugging and talking. But it's really intended to get people back to the frame of mind of why are we here. We're here to help. We're here to help our community and to do it in the best way we know how. And if we tried our best, we're all well trained for this, then the patient, that was their time. That's just what it was. And if you're able to keep that sense that you're here to help, you're here to impact people's lives in a positive way, the best way you can, then you should be able to sleep at night and go home to your families and hug the ones that you love.
I've seen you guys do that. I've even seen you include the family, which is really, really powerful. So what makes your job fun? Surely there's something easier out there than what it is that you do.
There's got to be hundreds of thousands of easier jobs than mine, but there's no job as fun as mine. I mean, nobody has stories like us. No one has the opportunity to be in people's, weirdest days, worst days, and help them. It's a ton of fun. And if you can imagine the people that actively pursue doing a job like this that is nights, weekends, and holidays for the rest of your working life, that's a group that you want to be around. Group of fun people, group of caring people, very much like-minded. And so what makes it fun is the people that you're working with and the population that you're able to help. We're in some ways the first line of defense, and in some ways the last line of defense. We're the only people out there that no matter what happens, if you show up and check in, we're going to take care of you, and we're going to do the best we can with all the resources that we have. So that's a lot of fun for us.
Well, Mike, I just have to say thanks. I've trusted my family with you. We want to mention in the news this week the measles vaccine. And so the measles vaccine outbreak is a danger to all people. In fact, adults over the age of 59% have confirmed measles illnesses. And these adults would not have been hit so hard had the vaccine rates declined in recent years, especially about fears of the vaccine and health risks. And another factor, many of these adults only got one dose of the vaccine before the CDC began recommending in 1989. In Ohio, the vaccination rate is 86%, the second lowest in the nation. Last year in 2013, there was an outbreak in Ohio among the Amish community. There's something called herd immunity, which is a statistical rate that is required to protect the population, and that's 92%. And so both of us, measles is a historical vaccine. We've never seen it. Please remember, vaccines protect yourself and your community. Next week, on Anderson Medicine, we'll be talking with psychiatrist Dr. Andrew Klafter about Munchausen syndrome and other interesting psychiatric facts. I'm sure we'll all feel better about ourselves afterwards. Thank you.